Thank you, Remy. Let me just start off by saying it's a great honor to participate in this esteemed panel, and I look forward to our further conversation. I want to start off by acknowledging that I live in Treaty 1 territory, the land of the Anishinaabe, Cree, Oji, Cree, Dakota, and Dene peoples, and the homeland of the Métis Nation. I respect the treaties that were made on these territories. I acknowledge the harms and mistakes of the past. And I recognize that ongoing present-day colonial violence that is faced by Indigenous people within healthcare, education, justice, child welfare, government systems, and I personally dedicate myself to moving forward in partnership towards decolonization in a spirit of reconciliation and collaboration. This is the framework in which I view the interaction of digital health with the public and public engagement. We're all familiar with the concept of informed consent. Research, be it digital research or any other form of research, starts off with the premise that the work that we're going to do needs to be ethical. And the Canadian Tri-Council has an ethical framework which talks a lot about informed consent. When we talk about digital research, however, there are two fundamental components missing from the concept of informed consent that mean we have to take a different approach in doing digital-based research. We don't have direct patient contact or participant contact to obtain consent. And also, we often are not fully aware of how that data will be used in the future for that research. So if we are going to recognize the challenges in both ethical research and engagement with the public, we need a different approach. So the solution to this challenge provides insights into the ethical future for digital health data use in the learning health system. I'm going to describe one solution that has evolved over about 20 years, which indicates that it has, over this time, had significant public engagement, even though it started in the United Kingdom in the Office of National Statistics. It is now called the 5 Safes framework. The framework suggests considering 5 dimensions of risk in addressing data management decisions. The goal, of course, is safe and ethical data use in research. On the slide, you see the 5 safes. One of the key components of this is to recognize that there is no hierarchy here. These 5 safes are presented in a circular pattern with the idea that one is no more important than the other, and each are equally important in and integrated into the idea of this framework. Each of these safes is not binary or absolute, but needs to be considered on a scale. And combining them, we have an approach suited to digital health future that can evolve as both our understanding of ethical data use and also the reality of data technology evolves. We are in a world where data technology is evolving very rapidly, as Remy has alluded to, artificial intelligence and the Montreal Declaration, which is an example of the need to respond to this. So each of these safes is introduced with a question. And you can see the questions under them on the slide. If we start at 12 o'clock with the idea of safe people, we need to recognize that the researchers who are doing the work need to have the knowledge and skills and incentives to act in accordance with the required standards of behavior. At the Manitoba Centre for Health Policy, where we work with digital data all the time, we have a process of accreditation where all researchers who have access to the data need to be accredited to use the data. And then prior to access, they sign a researcher agreement that indicates their willingness and agreement to work within the framework of that particular researcher agreement and the requirements that it dictates. Moving on, we look at safe projects, where the actual work that is being proposed needs to be recognized as being use of the data in a legal, ethical way, and that it needs to deliver public benefit. This is achieved through Research Ethics Board. We all know the role of Research Ethics Boards in ensuring ethical research. The setting allows practical controls in the way the data is accessed. And we heard of the current explosion of research using social media, where in fact there is no control in data access. So this creates a challenge and points out the need for an interaction between these 5 safes to ensure that no one safe is relied on, to ensure that the work that is being done addresses those ethical requirements and engagement principles. The data itself should have privacy and confidentiality issues addressed by identification, de-identification, should I say, and other techniques. We ensure that the data in our repository does not contain elements that make it identifiable, not just directly, but through combination of multiple data sets. We hold 90 different data sets in our repository, and much of the research that we do links data at the person level across these different data sets, which requires a cognitive approach to ensuring that linkage does not make data identifiable. Finally, when the research is done, there is the requirement to ensure that the results meet our ethical requirements. So a final check can be required to minimize the risk when releasing the data. So this next slide is an example of how we apply this. The orange at the top talks about the different levels of data access. We spoke a little bit about the data access that would be from a website or other social media. And as we move across to your right on the screen, we see different levels of data access, which can be through delivered access, providing data directly to particular users, and then even more safety through remote access, through specific data requirements, through a secure remote connection, and finally, access that's only acquired through on-site data use in a secure lab. If you look at how safe projects as the first safe is applied to these, we can see how the controls that are applied allow us to ensure that the project is safe through the 4 different areas of access. And I'm not going to go through those specifically, other than to say, as we go through each of the safes and apply these principles, and then put it all together through an integrated approach, we can ensure, to the best of our ability at this time, and recognizing that this is a rapidly evolving field, that we can ensure that we have ethical data use and ethical research. So I've proposed this as one framework that provides a useful approach to data access in a learning health system, both through administrative data, which is collected historically, and in fact, through that same data use in the current context. We currently get data, as do many of our other centers that we work with, on a real-time basis, if not real-time, certainly within a week or a month. So this is an opportunity to work with COVID data at this time and ensure that we are doing ethical research using this framework of the 5 safes. And I hope this provides some input into the framework that it will provide some useful discussion this morning. Thank you.
Well, thank you very much, Alan. Very concise, very clear. Thank you very much again. So the next speaker will be Jennifer Walker from Laurentian University. Jennifer.
Thank you very much. Thanks for that, Alan. That was very insightful. So, good morning, everyone. I wanted to focus a conversation a little bit on Indigenous data. Indigenous data specifically. So Indigenous data refer to all recorded information about Indigenous nations, lands, cultures, and peoples. If we think about it, data are and always have been important to Indigenous peoples for decision-making, for planning, for leading. You know, if I think about, so I'm Haudenosaunee from Six Nations of the Grand River, and you know, if I think about how data might have been used and how data continue to be used, it's a very central part about for planning, historically planning where and what to plant, knowing how many families there are in a nation, documenting important agreements, events, and stories. All of those things are data, and they have been and are important parts of how Indigenous peoples organize and make decisions. So increasingly, however, those data are digitized, and increasingly are also held by other people. They're held by other institutions or people, and the power that's inherent in those data ends up being held and controlled by others as well. So today we have vast amounts of cultural, historical, service-focused data, government data that are held about Indigenous peoples, but not by Indigenous peoples. So they can't be used in that same way for decision-making, planning, and leading. So it's another component of colonization that has disrupted this sort of traditional governance systems and emerging governance systems. So if we can turn for a second our minds to the United Nations Declaration on the Rights of Indigenous Peoples as a bit of a guiding framework for thinking about data sovereignty, we can see that the way that there are important rights that need to be considered, and that Indigenous data need to be handled differently than other types of data, so that Indigenous rights are honored and Indigenous self-determination isn't overstepped. So these things are quite complex, and they're complicated partly because of the complicated relationships that we have as nations, as settler nations and as Indigenous nations and people as part of all of that. So in Canada, many of these principles and rights are built into our treaties, but they haven't always been respected. Same with the United Nations Declaration on the Rights of Indigenous People. So a lot of institutions and individuals don't really know how to honor Indigenous rights. We don't have practice doing this well, at least in Canada and likely other places. So in Canada, since the 1990s, First Nations, one of the sort of constitutionally recognized groups of Indigenous people in Canada, have asserted a set of principles called OCAP. And some of you might have heard about OCAP before. If you see it, it usually has a registered trademark symbol beside it. And that's because there's a First Nations institution, the First Nations Information Governance Center, that has sort of the trademark to that set of principles and the sort of the term OCAP. OCAP stands for ownership, control, access, and possession. So it refers to First Nations rights to own, control, access, and possess First Nations data. So if there are data about nations, data about people that can be identified as First Nations people, then there has to be work to interpret what does OCAP mean in that context. So this set of principles has been a very impactful and effective way of communicating First Nations data rights, and has resulted in like a series of First Nations owned and controlled data collection initiatives that include the First Nations Regional Health Survey. There's surveys on education, employment, economics. But things become a lot more challenging when the P in OCAP, so that possession, is not possible due to federal or provincial legislation. So, for example, in Ontario, the province where I live within Canada, our provincial health services data are held and linked and used at a research institute called ICES. ICES is not legally permitted to send First Nations communities or nations their data when they request it. So we're sort of stuck on that possession part. So while ideally First Nations would be able to hold their data, link, federal, provincial, community data together to guide their decisions and do effective governance, it's actually really, really hard for nations to do that properly because their data are held by others who are legally, who have legal frameworks that they have to work with around the data. So that possession piece has become really challenging at ICES. So I have a role at ICES as a scientist and as a lead for Indigenous the Indigenous portfolio there. So what we established was a data governance agreement that worked those principles into a data governance agreement. So we have an agreement about how the data will be used that identify First Nations people. So this is an example of something that we've sort of I'm not going to call it a workaround, but in some ways it is because the possession part hasn't been possible. But what I also wanted to highlight for you is to share a new set of principles that were recently developed and released by a global Indigenous Data Alliance. And these global principles acknowledge that these data are often held at other places. They're not always held by Indigenous populations. So these principles were recently published, I think November 4th, early November, in the Data Science Journal. And they're called the CARE principles. So they kind of go alongside the FAIR principles that have been often talked about in terms of data centered principles. So the CARE principles underscore the importance of a collective benefit for inclusive, so the C is collective benefit for inclusive development and innovation, for improved governance and citizen engagement. And that C is really important because it talks about that, that principle that is so important to First Nations and other Indigenous populations of that need for it to be data to be used in a way that benefits their nations. The A is for authority to control. So that is the control piece of it. And that's not hard to do, actually. Establishing data governance agreements. So use and enabling that both governance of data and using that data for governance, enabling Indigenous peoples to be able to build their self-determination through the use of data. The R is for responsibility. So it's responsibility for our relationships to one another, for mutual capacity building and strengthening, and for honoring and incorporating Indigenous languages and worldviews when we're thinking about the way data are used. I could talk about this for a long time, so, but I won't dive in until we have a chance. The E is for ethics. So it's about minimizing harm, maximizing benefit, that we're using the data in ways that enable future use that are just and equitable. So things are evolving and changing, and there are Indigenous leaders globally really thinking through these principles that can help institutions to uphold Indigenous governance and uphold Indigenous rights in the use of data. Thank you.
Thank you very much, Jennifer. Much appreciated. I personally did not know about the CARE principle that was just recently published, and certainly this is a great opportunity, I think, for all of us to understand the challenge a bit more and the data ownership and all that. I'm sure we'll get back to that during the discussion. The next speaker, Catherine Régis de l'Université de Montréal. Catherine?
Oui, bonjour. Très bien, j'ai la présentation.
Good morning,
Alors, hi everybody.
everyone.
Bonjour, I'm very happy to be here. So I'm going to give the talk in French, but I'm happy to answer questions in French and in English. Donc, je vais vous parler aujourd'hui de la participation citoyenne comme condition essentielle de l'innovation numérique responsable. J'ai les deux scientifiques en chef on peut aborder la question, mais je vais essayer d'amener des éléments nouveaux.
So I shall introduce a few new elements during my talk.
Donc, le message clé utilement de cette présentation, c'est que la participation du public, mais je parle vraiment dans le sens large de la participation des citoyens, mais aussi des utilisateurs de l'innovation, est essentielle pour amener une innovation numérique digne de confiance, donc vraiment qui va mériter la confiance des utilisateurs, des citoyens, mais aussi pertinente, et pertinence dans le sens de applicable en réalité, un point qui a déjà été mentionné, et aussi bénéfique. La participation du public peut toutefois prendre plusieurs formes, et aujourd'hui, je vais aborder plus spécifiquement deux formes. Mais gardez en tête qu'il y en a vraiment plusieurs, et on peut les adapter dépendamment des fins recherchées. Tout d'abord, je vais parler d'une forme plus macro de vraiment que la participation citoyenne dans l'élaboration des normes, un peu formater le pacte social qu'on veut se donner pour guider l'innovation numérique, incluant l'intelligence artificielle, et aussi une forme plus méso, donc dans la conception même de l'innovation numérique. Dans l'élaboration des normes, en fait, cette participation citoyenne est importante pour assurer qu'il y a un développement de l'innovation qui soit en phase avec les valeurs sociales. Donc, vraiment, s'assurer que l'innovation soit connectée avec ce qui est au cœur des préoccupations, des besoins et des intérêts des gens, aussi ce qui est priorisé. Et aussi, donc, transformer l'innovation numérique avec ce pacte social et aussi contrer un peu l'effet de normativité qui est créée par la technologie elle-même. Donc, la technologie a un effet très normatif. Elle crée de la normalité dans nos habitudes, dans nos comportements, et vite, ça devient un peu la norme. Donc, essayer d'avoir des pactes qui nous permettent d'arbitrer finalement cette technologie. Et aussi, le pacte qu'on se donne va être important pour mériter la confiance des citoyens, et en lui-même, ce pacte, comme avec la déclaration de Montréal dont je vais parler dans un instant, fait partie du processus éducatif qui peut aider les citoyens, mais aussi les experts et toutes les personnes à s'impliquer face aux enjeux de l'innovation numérique et des préoccupations citoyennes. Donc, je vais parler de la déclaration de Montréal très rapidement. Donc, la déclaration de Montréal est un peu une boussole éthique qu'on s'est donnée pour guider les développements de l'innovation numérique. C'est un projet qui est à l'initiative de l'Université de Montréal, mais qui a été plusieurs partenaires, plusieurs collaborateurs, plusieurs chercheurs, dont justement le scientifique en chef du Québec qui a appuyé fortement le projet. Il y avait aussi des chercheurs de plusieurs disciplines. C'est basé sur un processus de co-construction. C'est comme ça qu'on l'a appelé, en fait, qui a au départ impliqué les experts qui ont élaboré des principes, une espèce de déclaration préliminaire, finalement, qui avait 7 principes. Et ensuite, une fois qu'on a eu cette première version, on a lancé un processus de libération citoyenne autour des enjeux éthiques et sociaux de l'intelligence artificielle. Et les gens impliqués, il y avait des citoyens, il y avait des experts, il y avait des professionnels de la santé notamment, mais largement, et aussi des partenaires de l'industrie. Et comment on a procédé, c'est par ce qu'on appelle des workshops, des ateliers de co-construction. Donc, il y avait des moyens de délibération dans les cafés citoyens, dans les librairies publiques. Il y avait aussi des
débats organisés avec différents acteurs et parmi les méthodes qui ont été choisies pour vraiment guider le processus de délibération, on voulait avoir une méthodologie solide pour le faire. Il y avait entre autres une méthode de ce qu'on appelle le co-design. Donc, on avait des scénarios prospectifs, et c'est ça l'image à l'écran. Ça va trahir un peu votre âge si vous reconnaissez la photo. Donc, on avait des processus, des scénarios en fait, qui projetaient les gens vers le futur pour les amener à anticiper les conséquences ou les opportunités que l'intelligence artificielle peut présenter et ensuite revenir vers le présent pour voir comment on voulait soutenir, comment on voulait développer des normes qui pourraient nous permettre d'éviter les risques, mais aussi d'amplifier le potentiel. C'est donc cette projection vers le futur qui a entre autres guidé le processus d'élaboration. Et ultimement, la Déclaration de Montréal est une combinaison de cette première étape de consultation des experts, qui avait 7 principes, si vous vous rappelez bien, et la deuxième étape de consultation citoyenne, et c'est la co-construction des deux qui a amené au dépôt de la Déclaration de Montréal, qui est maintenant disponible et qui a 10 principes, donc il y en a plus qu'au départ, 60 sous-principes, mais aussi plusieurs recommandations de politique publique. Vous pouvez aisément y avoir accès en ligne. Alors, voilà, dans les apprentissages de la Déclaration de Montréal, on a vraiment constaté qu'il y avait une valeur ajoutée quant aux résultats. Là, j'ai parlé des 7 principes de départ des experts, mais à la fin, on en avait 10. Et un exemple de ça, c'est entre autres l'importance de protéger la sphère d'intimité des individus est revenu très fortement comme préoccupation pour les citoyens, ce que les experts avaient moins anticipé au départ. Donc, il y a vraiment une valeur ajoutée dans le résultat de la déclaration, mais aussi le processus éducatif qui en résulte. Alors, dans les ateliers de co-construction, il y avait des experts qui étaient combinés finalement avec des citoyens, et les deux étaient en mode apprentissage, les deux étaient vraiment plus au fait finalement par la discussion des préoccupations, des enjeux, aussi la valeur scientifique, des préoccupations scientifiques. Et donc, en lui-même, ce processus avait une valeur importante. Et aussi, lorsqu'on a fait la déclaration, pour être sûr que les gens puissent participer activement au processus de co-construction, il y avait beaucoup de formations. Des experts parlaient finalement de la déclaration, pas la déclaration de Montréal, mais des enjeux de l'intelligence artificielle. Donc, il y avait ce partage d'informations. Ultimement, je pense que c'est très cohérent, ce processus aussi avec le droit à la science qui est prévu dans les normes internationales, où on dit que c'est plus que s'approprier les bénéfices de la science comme telle, ce qui était quand même se retrouve au cœur de la Déclaration de Montréal, mais aussi ce que ça veut dire le droit à la science, c'est de s'approprier les concepts, les méthodes et les théories scientifiques de façon ultimement à gagner en autonomie, en pouvoir sur la conduite de sa vie et aussi sur celle de la communauté. Donc, je pense que c'est en phase avec cette préoccupation. Ensuite, deuxième modalité de participation citoyenne possible, il y a dans la conception même de l'innovation, ce qu'on appelle le human-centered by design, qui a été mentionné précédemment, je pense, par la scientifique en chef. Si ça peut paraître simple au départ, c'est tout à fait le cas dans la réalité. Donc, c'est vraiment on développe l'innovation numérique qui est centrée sur l'humain et qui prend en compte les besoins des patients, des professionnels, des gestionnaires. Donc, ce qu'on appelle les end users, les utilisateurs de la technologie, et ça, dès la conception de l'innovation. Pour éviter finalement que ce soit uniquement les ingénieurs de l'innovation finalement qui formatent les besoins du système, mais que ça parte d'un besoin, d'une préoccupation réelle des utilisateurs. Et ça, ce que ça va amener comme grand bénéfice, c'est entre autres un plus grand passage, favoriser le passage de ce qui est développé en technologie à l'application pratique.
The transition between theory and practice, between the lab and the clinic. So we were able to close the gap in a way between development and the real world, because very often still
d'innovation, de recherche, et ce qu'on trouve finalement en application.
I believe that there is still a gap between the outcome and the findings of scientific processes and our own health, actually.
On doit essayer de réduire cet écart.
I think we need to
une des solutions, c'est entre autres de s'assurer qu'on développe des technologies, l'innovation qui part d'un besoin. Il y a des exemples de ça, j'en aurais plusieurs à vous raconter. Je parlais avec un collègue de Polytechnique Paris, d'ailleurs, récemment, il y avait aussi beaucoup d'exemples à me donner.
Mais juste quelques exemples. Il y a entre autres une technologie qui a été développée pour aider les médecins finalement à avoir plus d'informations lorsqu'ils rencontrent le patient, ou tu peux sur ta tablette intelligente lorsque tu es en attente à l'urgence, on a le temps normalement à l'urgence, de remplir finalement un questionnaire à un espèce d'algorithme qui te dit si tu as mal au genou, finalement clique là-dessus, après ça il essaie de donner une information plus précise sur les besoins du patient. Cet outil-là est décrit avec une mobilité innée, donc tu peux juste avoir mal au genou, tu peux juste avoir mal à l'oreille par exemple. Mais tu ne peux pas avoir les deux en même temps, c'est une réalité qui est évidemment présente. Alors, l'outil est un peu utile aussi dans les soins à domicile, pas l'intelligence artificielle nécessairement, mais juste un questionnaire qui guide les travailleurs sociaux. Et on mentionne si le patient, par exemple, ou l'usager a un problème de poids, trop maigre, ça veut dire nécessairement dire qu'il n'a pas mangé. Or, ce que nous disent les travailleurs sociaux, c'est que je sais qu'il a bien mangé, c'est pas ça le problème, mais si je coche pas la case, je peux pas sortir du questionnaire. Donc, vraiment des outils qui sont peu adaptés, ce que ça peut amener, c'est un rejet de la technologie elle-même, donc des pertes financières importantes, une perte de confiance dans la valeur de l'innovation numérique, et aussi une perte d'opportunité. C'est vraiment faire des occasions de faire de l'innovation qui va avoir une valeur ajoutée. Ultimement, aussi une préoccupation, c'est la possibilité d'avoir une atrophie du jugement humain. Donc, si on est trop cadré par ces outils numériques où on a une perte de jugement discrétionnaire, ça peut vraiment limiter cette valeur ajoutée de l'humain qui doit vraiment s'intégrer à la machine. Donc, en conclusion, je sais qu'on a plusieurs points à discuter, mais moi, c'est toujours mon fort. En plus, quand je pense à l'innovation numérique, c'est toujours me projeter dans le futur en me disant lorsque l'histoire va nous juger sur cette étape charnière de mutation sociale qui est liée à l'innovation numérique, mais aussi potentialisée avec l'intelligence artificielle, on le voit bien. Est-ce qu'on va être fiers du progrès social qu'on va avoir puisé pour tous dans cette innovation? Et je pense que la participation du public est entre autres essentielle pour
Public engagement, in my opinion, is of paramount importance in order to answer this question with a yes. And on this note, I conclude and thank you very much for your attention.
Déclaration de l'UNESCO, le droit à la...
Thank you so much, Catherine. Thank you for raising the issue of the right to science, of the UNESCO Declaration as well. And I think it all comes back to the core principle of open science, doesn't it? I believe that if there is one thing we can say here is that open science has been especially useful since the beginning of the pandemic. So now we have Tanya Bubela from Simon Fraser University.
Thank you very much for the invitation. And I would first of all like to acknowledge that I am on the beautiful territories, unceded territories of the Squamish, the Musqueam, and the Tsleil-Waututh nations here in North Vancouver. So we spend a lot on healthcare. About nearly 12% of our gross domestic product in 2019, and increasing expenditure is simply not sustainable. So we have to better manage the development and integration of safe, effective, and affordable diagnostics and therapies that are accessible across Canada and actually make a meaningful difference in the lives of patients. So one way to do so, and Alan had talked about this, is moving to a learning health system that sits at that interface of clinical care and research. So learning health systems generate and apply evidence to improve patient health, drive discovery as a result of data from patient care, and ensure innovation, quality, safety, and value for money in healthcare. And they're based on large amounts of shared and accessible data. Learning health systems can support the evaluation of new technologies, such as diagnostics and therapies, across their whole life cycle. And such evaluation can inform the adoption of new technologies, but also, more importantly, the re-evaluation of those technologies so that we can make de-adoption decisions sometimes. So this system of life cycle health technology assessment is characterized by the standardization of data collected based on real-world evidence of resource utilization and health outcomes. I'm going to provide two brief examples One is COVID-19 related from the UK, which is a leader in learning health systems, and the other one that's related to the adoption and evaluation of precision oncology. So in the context of COVID, the example I'm just going to give you very briefly is the UK recovery trial and the parallel trial that was run by the World Health Organization, the Solidarity trial. And these were proof in principle that standardized clinical protocols, including consent processes, randomization, and analyses, could be rapidly deployed across health systems to evaluate the safety and effectiveness of potential interventions for COVID-19. In fact, by June, the UK recovery trial had run at hundreds of sites across the National Health Service, had demonstrated that the anti-malarial hydroxychloroquine and the HIV antiviral combination of leponavir and ritonavir were ineffective at treating COVID-19, but that dexamethasone improved decreased death by up to 1/3 in ventilated patients. So it's a huge number of patients that were enrolled very, very rapidly in this integrated feedback loop of care into the health system to inform decision making. So in the context of precision oncology, which is the space where I work, you know, the UK clinical recovery trial basically said, if we can do this during a pandemic, what's preventing us from doing this for other diseases like heart disease and cancers? And that's exactly the question that I'm asking myself and trying to answer in some of the work that I do. So indeed, there's an emerging paradigm shift in cancer care that's called precision oncology, and it's necessarily premised on a learning health system. Precision oncology uses omics data to select actionable tumor mutations independent of cancer type. However, more evidence is needed to support its broad adoption because a minority of patients may have known driver or actionable mutations, which increases uncertainty. Targeting multiple mutations with combinations of therapies may be too toxic for patients. Concerns exist about data consistency and reproducibility between different test sites. And limited evidence exists of efficacy and cost effectiveness to support reimbursement of the therapies in this approach. So multiple initiatives are underway globally, especially in other G7 countries like the UK, US, and France, but also here in Canada. And these are based on systems that endeavor to support the integration of multi-omics data with other health information, creating an iterative loop between evidence generation, clinical decision-making, and intervention evaluation. So you can't do this without the patients. It's absolutely critical to have participant engagement. And Catherine was talking about co-creation of knowledge, and that's absolutely what's essential here. So as illustrated by these examples, a learning health system and our ability to evaluate technologies across their life cycle is premised on data platforms that sit at the interface of clinical care and research. And the data governance in this context requires patient engagement to enhance trust, accountability, and representation of patient and societal interests. And so what we're really moving to is kind of models for consent for governance and patient participation in the establishment of the kinds of governance principles that my co-panelists have been talking about. Further, in designing pragmatic clinical trials, patients need to be engaged in understanding what we mean by clinically meaningful outcomes. You know, what's important to patients in terms of outcomes for clinical trials, and including, in addition, when we're trying to make adoption or reimbursement decisions, we need patient engagement in what are the values or the social and ethical values that that decision makers should take into account when making resource allocation decisions to adopt new technologies or to disinvest from them. So in conclusion, to support learning health systems, we need a new data infrastructure, participatory approaches to data governance, and adaptive regulatory systems. And these include consent processes, privacy protections, clinical trial design, research ethics, and operational approvals. But unfortunately, in our multiple health systems and provincial structures, we self-inflict wounds. These pose challenges for clinical research on a national scale, such as basically being able to do something like the recovery trial here. And I'm happy to take questions on that, and thank you very much.
So, thank you very much, Tanya. I think what you mentioned also, the lesson learned from the pandemic, a lot of challenge in the pandemic, but maybe some positive aspect also can be the system can be more agile, more flexible, always, of course, focus on excellence. But I think there is a lesson there that we should not waste when we're done with that famous pandemic. The last speaker of the session this morning, Karine Lefebvre from France, from Paris.
Okay, so thank you very much. So first, I would like to thank the Royal Society of Canada and particularly Chad Gaffield, past president, and Jeremy McNeil, the new president. So congratulations for this new position. I'm very honored to take part in this G7 summit for the second time. And I want to focus I want to focus in this presentation on the emerging issues in the CCNE and CNPNE opinions about ethics and health democracy. Just to remind, the CCNE is the French National Consultative Ethics Committee. I'm vice president of this committee, and I just remind you that the president is Jean-François Delfrécy, that was also nominated during this crisis as president of the Scientific Council near the President Emmanuel Macron. So it's a specific period for all boss. And just a word also about Claude Kirchner. It's a chair of the French National Pilot Committee for Digital Ethics, the CNPN. The CCNE was created in 1983, and the CNPNE is new because it was created at the end of the 2019. Just a short reminder of the context in introduction, and after I will talk you about the major CCNE and CNPN opinion during this crisis, and that it's not finished, but we worked a lot. And in second part, the main ethical issues relating to ethics and health democracy. So to introduce my contribution, I just want to speak about the need of an ethical light. I think it's maybe the first lesson of this since the beginning of this crisis. The need for meaning of for all population, all researchers, all health professionals. Because it's an expecting period with very complexity, with stress in all the world, and in France, I'm sure it's the same thing in Canada. There is a looking for new landmarks, and it's very interesting to see that the term of consideration, not consideration, but consideration was very used. It's a context of health emergency, and that in the side of the balance there is a restricting public and the question of rights and security and liberty and individual freedoms on the other side. There is also a strong increase of digital usages and a lot of questions with this. So maybe the main question is that which place for ethics and citizen deliberation in the decision-making process, and it was very interesting to hear the previous presentation. So how we worked. So the CCNE and CNPN during this crisis, maybe the first thing is that we worked a lot in a very short time, because these two ethical French committees were a few times requested, and that is very interesting, by the Ministry of Solidarities and Health. For example, the CCNE was four times requested, and we also had self-referral, or we took position, and there are a lot of opinion about different issues, of course. Just two slides to remind the different dates. You can see that for the CCN opinion, it's in French. We focused on the ethics from the beginning and through the different steps of this crisis, sometimes about specific population, like vulnerable population, like the issue of protecting measures in the institution for elderly, like the ethical issues at the end of the first confinement, the first lockdown. And the last one is from 19 November about ethical principle, ethical issues about prioritization in hospital and access to health for all people. And for the CNPN opinions, you can see that they produced a lot of bulletins de veille, also from the beginning to now, and sometimes about a very specific question in digital field, digital health, like disinformation, like chatbots, like telemedicine. So a very strong production. Through this production, we can find key questions in the beginning about digital health. And of course, specifically CNPN spoke about possible intentions between public health imperatives and, of course, the preservation of fundamental freedoms, and about the use of digital tools, and also inequalities or discrimination that they could lead to. Of course, there was also a tension between urgency of decisions, of politic decision, and of course, robustness, security, and sovereignty, and ethics principles. For example, also, in one of the first opinion of the CCNCP, so the French Committee for Digital Ethics, there is a reflections and warning points on digital ethics issues in situations of acute health crisis. And I invite you to read this opinion on the website of CCNE, because there were two focus on fraternity and tracking of individuals with digital tools. And to finish this short presentation, what about the main ethical issues relating to ethics, health, democracy, and digital? maybe I can say that as the vice president of the CCNE, and I work also a lot during this crisis with the other committee in digital health. One of the lessons is that we shouldn't sacrifice the fundamentals of ethics, and you can read one of the lesson of in the last opinion of the CCNE in November, that said an exceptional situation should not induce an exceptional ethics. Really, it's very important, because on this specific time and the very short time, and with a lot of emergencies, it's very important. So this intangible principle must be should be reminded as dignity, principle of proportionality, adequacy, and regular control of restrictive measures for confidence of citizens, for protecting of rights. It's very important. About health democracy in France, it's very interesting to focus on the paradox, because we have a lot of law that focus on the importance of health democracy. And during this crisis, all associations of patients, all instances, including CCNE, say that be attention, because we don't ask enough the express of will of the patient, of the citizens. It's very interesting to see and to notice. And that's what is interesting is that just yesterday evening, President Emmanuel Macron said us that for the first time there will be a collective citizens that will be created for vaccine question. So the red wire in the CCNE and CNPN opinion is that a major issue of acceptability and citizens engagement is important. Être informé pour comprendre et comprendre pour être acteur. So a patient must be informed to understand, and must understand to become actor. So transparency and information decision-making progress is so important, and to restore public deliberation. We spoke a lot in France before the crisis about public debates, and the CCNE and CNPNE said that they wish to create a public deliberation at this time or in the next future. So you can see maybe the key words we heard the most time in France: responsibility, individual or collective, solidarity, confidence, protection of vulnerable people. We have to pay attention about precarity and social cohesion, social link. And of course, in the digital health, we must looking and understanding for the meaning of measures and using an individual tracing. So how to conclude, maybe which lesson can we learn about this crisis? Certainly we have to operate both level of health democracy and ethical reflection. And we have also to initiate a collective reflection, as I told you just before, especially on the limits of health system. We speak a lot at this time about the issue in public health and also about social issue. What sort of conception of health do we have? How can we live together? Which sort of solidarity we will have together? And of course, the issue of confidence and citizen engagement. You can see here a little another way to speak about ethics. I very like this. I like very much this cette belle image de Santé. So many thanks for your attention. You can see the website, and I invite you to read these many contributions during this crisis. Thank you very much.
Oui, merci beaucoup, Karine. J'ai bien aimé.
Thank you, Karine. I loved the sentence that one had to be informed to understand, and to understand to be an actor. I believe this was said, and well said. We are now moving to the question and answer session.
You can put it in the chat. I will ask also maybe Amber or Connie to put them in the chat for me. It would make it a bit easier for me from the participant. But before that, a couple of questions from the speaker, my side, and maybe after that I will ask you also if you have a question for your colleague this morning. Two questions, and I'm not sure exactly which one we'll like to answer first. Since we are talking about G7. In terms of ethics, privacy, and public engagement, do we have a first in class among the G7 countries? Where do you put Canada there? Or is it too simplistic as a question and there is no first in class? There is no country doing a bit better? Or if there is a country outside the G7 that Canada should try to emulate? I would like to know a little bit more about that. And then in terms of ethics, privacy, and public engagement, what is the impact, good and bad, of social media? So maybe I'll ask Catherine to start. Avec le micro.
Can you understand me now?
Yep.
Okay. Okay, so big questions. I guess I will try to respond to the first one. So regarding the topic of my talk today, public engagement, so I think Canada was, well, with the Montreal Declaration, was pretty innovative in that sense. A lot of countries do work with public engagement and digital innovation. I'm thinking about the UK, for instance, and other countries. But the fact that we had this very, not unique, but certainly original mechanisms where we co-constructed the knowledge between the experts and the citizens, I think that was something that we can be proud of, but something that can emulate other changes. And we had the occasion to present this declaration around the world, and I can say that it was well received, and it was mentioned as one of the best ethical tools for AI around the world as well by experts. So this is something good. I also want to mention that this process is now serving as an example to do the same thing, but at a more international level. So really try to implicate the citizens in formulating norms to guide AI and digital innovation more broadly. So, you know, it's connected. It's difficult in this area to stay really local, which is, as a legal person, something that is normal for the law. Like, it's usually a local matter, but these challenges really go beyond the frontiers, and we need to scale this thing up, and this is going to be the next step. And I think it's something certainly that can inspire, and is already doing with the UNESCO, for instance. This is something they are already doing, try to use that experience and put it in international norms eventually.
And for social media?
The question was, what's the impact of social media?
Yeah. Good and bad in terms of ethics, privacy, and public engagement.
Well, you know, social media, there's a lot of public engagement for sure through social media. I'm not sure I have something that consequential to say about that, but it's certainly an option to be involved, but we saw also all the failures or the challenges that it poses for sure for healthy debates, and how we can use that either for research or really to stimulate and very engaging and fruitful dialogue. That's something that I think the nexus of that relationship still need to be figured out. But yeah, I'm sure I'll leave the others to answer that.
Yeah, in relation with the big GAFA as well. Want to continue on that, Tanya?
Sure, I'll pick up a little bit on the social media question. The social media is understanding the social media environment in addition to being able to use it as a platform for social engagement is really important, because there's a lot of information that is out there that needs to be contextualized for consent processes and for democratic deliberation. You need to know what other information or misinformation is floating around in the social media ether in order to be able to have meaningful conversations. And so in the clinical trial context, media can contribute to misestimation and therapeutic misconceptions amongst patients if new technologies, for example, their benefits are overly hyped. Hydroxychloroquine would be one of those stories. And so it can create pressures on health systems if the evidence is potentially, or the information about the evidence is a little bit over the top. And so understanding that environment so that you can actually incorporate it into your consent processes is really important in the clinical trial context.
In relation to G7, is there a model among the G7 countries?
Yeah, so I talked about the UK as being really a leader in the learning health system. They have a somewhat easier system to work with than Canada because they have the National Health Service. There's actually very good models in the US as well, even though they have a very fragmented health system. The ones that they have that actually employ these kinds of technologies, things like Kaiser Permanente or the VA system, are actually very good at what they do. It's just that not everyone has the same level of access. In Canada, the frustration is that we say we have a public health system, but actually we have multiple health systems. And we can't even talk amongst the health systems within a province, let alone between provinces. And so that really can set up some challenges within doing anything in a coordinated fashion. So it's much easier to do things with consent moving forward in a networked fashion, but you have to plan that. It's much harder to integrate legacy data or look backwards in Canada because of the way that we interpret our privacy and operational legislative frameworks.
Yep, thank you very much. And we saw that very much during the pandemic, the discussion between the province and difficulty and challenge, and with the federal. So certainly, Mona and I have talked quite a bit about that. In relation with social media, I think many of us, and including at the level of office, Prime Minister office, the daily email from citizens saying, "I know this worked. Why is it that you do not basically adopt it and offer that to a patient that suffer from COVID?" So a lot of pressure there from a lot of members of the public. So maybe Jennifer.
So, it's interesting when we're thinking about Indigenous data, often we're looking to examples in New Zealand and Australia. So maybe outside of the G7, to be thinking about leadership in the way that data sovereignty for Indigenous peoples is honored, particularly in New Zealand. I think recently, the Maori Data Sovereignty Network has made quite a bit of progress in their relationship with Statistics New Zealand. So I think that, and the conversation about, okay, sorry, I'll actually just step back. I was going to jump to social media, but I'll say one more thing. And that is that, in Canada and the US, and Australia and New Zealand, we have different ways of identifying Indigenous people in the data, whether there's mechanisms for people to self-identify, whether we conflate indigeneity and race, and we think they're the same, Indigenous identity and race. I don't know if you recall, there was a moment during the U.S. election where CNN had, Black, Hispanic, white, Black, Hispanic, and something else. And so there was a lot of dialogue about what that something else meant, in terms of race. And I think that, so those kinds of like the conception, the sort of public conception of what Indigenous identity means and what about it needs to be considered really differs in different places. So it might not differ so much from Indigenous nations' perspective, but it definitely differs from the sort of nation-state perspective. The other, around social media, I think I don't have a lot to say here, except that, I think it's important for us to think about the costs and benefits, so that, if we're encouraging and structuring our public engagement using social media, there is a cost to that in terms of, who owns that data, where it goes, how it's used, and the potential for how that might be used for individuals who are trying to engage with us. So I just think we need to think about the ethics of that in lots of nuanced ways that I think we're just learning about.
Okay, thank you very much. Probably more research certainly related to social media and the impact of social media. Alan.
Thank you. Really interesting presentations and conversations. So I see social media, I'm going to start there for the moment, in two different ways. Social media democratizes data. It brings forward a potential understanding to, as it were, the masses, those who don't read scientific journals or get their data from places like that. And of course, it's a two-edged sword. So on the one hand, the data that's in social media itself, in terms of looking at analyzing social media, has huge challenges. And it provides a huge challenge, I think, in the context of trust. Because a lot of what's out there in social media is of questionable value. And those who read it don't really necessarily have either the skills or the desire to understand and interpret that data in a meaningful way. So we've created this environment where there's the trust in data itself, I think, has been undermined by democratizing data through social media. I would also point out that those of us who work in administrative data and data that's collected through a variety of different mechanisms have, for population health data in particular, have, to be honest, regarded this as being relatively unbiased data. This is the whole population. This is an advantage to work with this data. And now we're learning that, in fact, no, this is actually racialized data. There are a number of influences in this data that we never really considered in the past. So I'm finding it very challenging but refreshing to have to reconsider how we consider the data we work with. I'm not an expert at the topic internationally, but I will say that the 5 Safes framework, which I think is a very valuable one, was developed in the UK. And if you looked at my slide, the source of the slide actually was from Australia. So it has those two countries clearly have worked in this area more than others that I'm aware of. I think the challenges in Canada of our federated system and the provincial jurisdictional nature of data have been mentioned, and is a huge challenge. In terms of administrative data, we now have a capacity through the Health Data Research Network Canada to start addressing those challenges. And we have an initiative that's just been announced in terms of a national data initiative. So I think we're moving in the right direction, but we in Canada have a huge disadvantage in how significant, how powerful our jurisdictions are in this area.
Yep. Thank you very much. And I fully agree on that one, the last one. Erin.
Oui, merci. C'est vraiment très intéressant d'entendre vos regards croisés.
Thank you. It was extremely interesting to hear what you had to say. So I'm going to speak French now, just to make it interesting. So in terms of controlling the quality of data we have access to through social media, I think we need to come back to what we call the citizen conscience. And I think this comes back to what Catherine said earlier about the right to science. How can we help people who have access to this massive amount of data so that they can recognize which data is actually evidence? So much can be said about conspiracy theories, about the incredible amount of fake information we find on the internet. And a lot has been done actually over the past few years on scientific and health data. And I believe it would be quite useful actually to raise the awareness among users about the trustworthiness of this data. In our National Ethics Committee, we are currently working on the issue of consent. We are looking at the citizen consent now. And this once again comes back to what Catherine said earlier in terms of consent and governance. Thank you so much, Karine. You can rest assured that a lot is being said and done here about digital literacy, for instance, because many groups don't even have access to the information in general.
Following their presentation. Go ahead.
Oui, merci. Alors,
thank you so much, Rémi. So, I'm very interested in what Catherine explained earlier on when she recruited citizens for the co-construction process. How did you recruit these citizens for these common deliberations, and how did you assure the highest degree of representation, and how did you go about this? It would be very interesting for me to understand. So I will keep speaking French. So thank you so much for your question. So if you want to understand the entire process of the Montreal Declaration, you can go to the website. All the reports are on the site, all the reports on the methods that we chose, how the participants were chosen and recruited. So if you're interested in that, it's all on the website. Obviously, there is no 100% perfect representation of the population in focus groups. So what we try to do is having groups through contacts of people we knew, and then we tried, obviously, to have all the larger stakeholders involved as well. So that's what we tried to do. And I'm sure that not everyone was represented in our groups. There are about 8 million people in Quebec. So we tried to Obviously, if you want to scale it up to French population, it would be quite a different exercise. So we tried to be as representative as possible, but as I said, I don't think there is a real way to achieve perfect representation. But there was a certain emulation effect, because when we invited people, these debates and these citizens' café, where the experts were presenting all the stakes of artificial intelligence, then people who participated in these citizen cafes were talking about the issues with other people, with their friends. So I think it was quite important, actually, and I don't think we talk about it quite enough, because in somehow there is a web that's self-created around the issues, and that is quite interesting. I know that UNESCO is actually trying to organize the same time of public engagement scheme and co-construction and citizen deliberation. So we haven't seen the end of it, that's for sure. Does anyone have any other questions? Catherine, maybe? Tanya?
I'd like to pose a question to Jennifer and Alan about identifying priority populations within data sets, and the general movement in Canada around a more granular understanding of the populations that are being treated and the data that are being collected within our health systems. And Jennifer, your point that might help identify the data over which there needs to be control or OCAP or care principles applied, and Ellen, from the perspective of actually understanding some of the inequities that emerge from our health services research.
Thanks, Jennifer.
Thank you for the question. Yeah, so I think it's the sort of efforts that have been made so far, are really driven by Indigenous governance organizations in many cases, who define the population the way they need to define the population, and then we work with it, right? And we can find ways to identify those groups through data linkage or others. So, for example, in Canada, there's a national registry of First Nations people with status. So when we work with Chiefs of Ontario, that's the registry they want to use. The Métis Nation of Ontario, another Indigenous group, can bring their registry and link to find their population. From the perspective, so that's really helpful for governance, right? So to support the governing organizations to govern. So the goal that you're talking about also around a health system wanting to make sure that there's that they understand the groups that they're treating. So the kinds of things you're talking about around equity and things like that, that's a different goal. And populations would have to be identified in a different way, because from the perspective of a health system, so from the perspective of the Chiefs of Ontario, there's no gaps in that data, right? They have who they need to look at, and they have their citizen, their population. But from the health system, there's gaps. And so I constantly hear this, we need to fill the data gaps, but it's not a gap from the perspective of the Indigenous governing organization. It's a gap from the perspective of the health system or the government, like the provincial or federal governments. And so it's really important to keep the goals in mind that we have when we're doing this work, and not to confuse the goals. And so, for example, when we have diverse urban Indigenous populations, and you have urban health service providers providing services to those populations and wanting to understand those populations, there would be a different way we would need to identify those populations. Those registries wouldn't work for those organizations or for the health system. So, so yeah, I think there has to be a diversity of ways, and we need to understand the goals. I tend to work on the sort of side of trying to ensure that Indigenous organizations have the data they need to have, and that they can identify the people in the data sets that they need to identify to be able to make decisions for those populations. But there are lots of different goals that we have to work on throughout the whole ecosystem, and maybe Alan can speak a bit more about the sort of idea of identifying priority populations and things like that. So I try not to see my work as, you know, Indigenous people are equity seeking, or, you know, this sort of like in the context of the sort of like need for, like, as a vulnerable population, but rather, you know, in this context of governance and self-determination. But I do recognize that the inequities that exist require that we look at it also from a health system perspective.
Thank you. Thank you, Alan.
Thank you. So for years, I've gone to a conference called the North American Primary Care Research Group. And this is a bilateral group of researchers in primary care, mainly from the US and Canada, but now it's quite international. And I was struck by how US researchers traditionally report their data racially. And Canadian researchers never did. They never had that racial breakdown. And the misconception was that in Canada, everything was equal and we didn't need to report it that way. Of course, that's totally incorrect. And we have not traditionally collected race-based data in Canada. So in terms of what you called legacy data in your presentation, and the retrospective data and administrative data that exists within our healthcare system, within our research centers and the repositories, we just don't have that data. Jennifer referred to the national registries of First Nations, and in Manitoba we have a Métis registry as well that we use with permission. But for many years in Manitoba we have been able to do analyses based on socioeconomic status. So the social determinants of health are clearly critically important in trying to understand inequities in health. And we have been limited to ecological data traditionally in terms of dividing the population into income quintiles based on where they live, for instance, which is a significant limitation in how we do those analyses. And it doesn't allow us to get to the granularity that would be helpful. To address that gap, we actually need to collect data in real time, race-based data, for instance, and other more sensitive data from patients who access the system and use that data within their care. And this is a very sensitive area, and we're not particularly experienced at doing this. So I, for instance, am part of a research project led out of Ontario by Andrew Pinto, which actually is funded to address this question. Is how can we ask these questions in a sensitive, a respectful way that allow us to gather data around patient ethnicity, for instance, that allow us to provide care based on that reality. When I go back to my initial presentation in the 5 safes, collecting the data is only the first step, and doing it in a sensitive way is only that first step. Once that data is collected, it has the potential to be used in inappropriate ways. And that's one of the concerns I have around collecting, for instance, race-based data. And in our population-based repository, we don't use any of our First Nations identifiers or Métis identifiers without specific consent from the sources of that data. And that requires a specific ethics committee that understands that the use of that data is going to be for the benefit of that population. When you're doing it at an individual level and collecting that data, it's much more difficult to put those kinds of criteria in place and ensure that the data you've collected will be used for the benefit of the population that you've collected it from. So while we're talking about how to collect the data in a respectful way and an appropriate way, I don't know that we yet have the answers in how to use it in an appropriate way. So I think we've got a long way to go.
Thank you very much. I think we'll move into a few questions from the audience, and I ask one that kind of continue on what you're just saying, Alan. The question is, in the context of the 5 SAFE, who should decide if it is a SAFE project? Is an REB review sufficient?
So I would answer that by saying that it is necessary but not sufficient.
So what's missing? What it will take?
So specific projects may have impacts upon specific communities. For instance, the issue of, as we have the capacity now to do research with First Nations data, the REB cannot be the final arbiter of that. That is data that we need First Nations input for, as an example. And I think there are other cases where we at our Center for also when we use social data and we link health data to, for instance, data that involves children who have been taken into protection by social services. Prior to the use of that data, the researcher needs to apply to the data custodian who has collected that data in order to use it. So the REB provides the high-level review, but I think there are frequently times when we need additional permissions to ensure that to review it and ensure that it is a safe project.
Any additional comment, Jennifer or the other speaker? Jennifer? Just one. I think that when we think about the capacity we need in our researchers and our institutions to be able to do this kind of work safely, that it requires an investment there to help people understand. So it requires both those sort of processes and the policies to support the safe use of data and in the 5 SAFE framework, but it also really does require us to build our capacity as researchers and users of data to be able to work in good ways, and also capacity in the populations that we're talking about to make sure that we can have these conversations about data in a informed way, I guess, mutually informed way. Merci. Any other comment on that one, or we go to the next question? So maybe the next question from Mona.
Oui, merci Rémi.
Thank you, Rémi. Thank you so much.
Questions, and just on the practical aspect with the management of the present pandemic, maybe I have 2. One, if we take the sort of right to science, le droit à la science, for the public, and what would that translate into in terms of the information that should be made available to the public? And I have in particular, a number of data, for example, that, virus genome sequencing, we're challenged by just being able to share it across our provincial lines and so on. And the other one is also the data, and we talked about the intersection of different databases. So, in the present case, for example, with the COVID, if we collect only racial data, and we don't collect other data information in terms of employment, in terms of, housing, activities, and so on, we might well end up with the wrong answer. So, how can we determine the extent of invasiveness you know, of the data collection and of the, you know, sort of private right to privacy, and then the collective good.
Thank you very much, Mona. Big question. Who want to give it a try? Catherine, Tanya?
There's kind of two questions there, right? So perhaps I'm going to try to answer the first one, but it's more of a comment. So first of all, the right to science is really underused as a right. We often call it the Cinderella right. So there's a lot of space there to really kind of mobilize further this right and try to give it more shape and more content. And although we already have some valuable tools to give it content. So in this instrument, as I mentioned, I think this is the key point actually in this right, is it's not only about ensuring access to science, like the specific access, but it's really about building capacity and empowerment for citizens and users more broadly. And this can take different forms, right? So I guess when you ask the question about what kind of information during COVID and other crises or any situations about how can we mobilize this right to make sure that we give the proper information, it really is about ensuring this capacity to have some autonomy in your life to make decisions about COVID, about the risk, about the challenges and so on. So it's kind of a broad tool to really reflect on this, on our obligations. But at the end of the day, I think we have to ensure that it really is about empowerment and giving autonomy to people. So do that information about COVID would help people to do that. I think it's kind of a framework to see it. But I really hope that we will further build on this right to use it in different contexts in science to make sure that we really give all the tools to people to build on that right.
Oui, parce qu'aujourd'hui, c'est la COVID, et puis demain, c'est l'environnement.
Indeed, today it's COVID, tomorrow it'll be environment, or at the time it's environment. Just to mention one element of our life, it's so many dimensions.
I would always say I'm always a little bit cautious about rights to language. So sometimes I can be a bit of a downer because rights come with corresponding duties and obligations. And so I think those need to be balanced. And some of the duties and obligations of the scientific community are to, you know, work in the public good, but also to have those levels of controls around the quality of the data that is being put out there. I mean, science is self-correcting, and some of the confusion that arises I think in terms of science communication, or some of the difficulties around science communication, come from the lack of understanding that science is a process and it's a self-correcting one. And that you know, retraction or revision of initial viewpoints is a natural part of the process. And so, as part of those duties and obligations, I think it's really important what, you know, Jennifer and Alan have been talking about, which is really about, you know, who has control over the data, how those data are collected and used respectfully to enhance and empower people. To have in the context of you know, in data around Indigenous peoples, to enable data sovereignty, in the context of the kinds of things that Alan is talking about in terms of the 5 safes, to, you know, to make sure that those data are used for the betterment of the people from whom those data are collected, or on whose behalf those data are collected. So, you know, it's a double-edged sword.
Yep. Any other comment on Mona's question? Or is it okay? We are at the end of the session now. Just a couple of minutes, so I'd like to thank all the speakers for your presentation, for the discussion that we had after. I'm sure we could have discussed for many more hours, because there is many thoughts. Just what we discussed will not be resolved. over the next little while will take a lot of research and works from some scientists and also from the public. We discussed a lot about public engagement. I think also we'll see today at the other session on promise and pitfall of data science and AI, data governance, winning condition for scaling digital health innovation, all relate to what many of the topics that we discuss here. And maybe if we come back at the end of the day, we'll have another series of questions and comments to all the participants. So hopefully Chad, when he will summarize the discussion of the whole day in a few minutes, he'll be able to tell us what is missing and where we should go next. So thank you very much again. Merci beaucoup à tous et bonne discussion aujourd'hui.
Thank you very much to all and have a safe day.
Thank you.